Good morning, afternoon, or evening. I'm Sona Jain, and on behalf of the American Association for Hand Surgery, I'm pleased to welcome you to our global hand-in-hand webinar series in collaboration with the Taiwan and Hong Kong Societies for Surgery of the Hand. Today, we'll be discussing tips and tricks for CMC arthritis, arthroscopy, trapeziectomy, denervation. It's my pleasure to introduce you to our moderator and series lead, Dr. Harvey Chim from Louisiana State University in New Orleans. Harvey, take it away.
Thanks, Sonu. So again, thank you everybody for joining us today on this Saturday morning or evening. So good morning, good afternoon, good evening, everybody. We have a great lineup today, and I think we're really going to learn a lot of things about CMC arthritis. So it's a global hand-in-hand webinar. Dr. Zhui Tianxi is representing the Taiwanese Society for Surgery of the Hand. He's from Armed Forces Taoyuan General Hospital. He'll be talking to us on arthroscopic RTI. Esther Chow is currently the president of the Hong Kong Society for Surgery of the Hand, and she works at United Christian Hospital in Hong Kong. And she'll be talking to us about arthroscopic first CMC joint arthrodesis. And then Marco Rizzo, who needs no introduction, will be talking to us about all open approaches for management of CMC arthritis. And finally, Sami Tufaha is going to talk to us about denervation for thumb CMC arthritis. So please, if you have any questions, please put them in the chat and we'll try to answer all the questions. So without further ado, I would like to invite Dr. Shi to kick us off.
Okay. Do you see my voice?
No, we don't see your slides yet.
Okay. It's okay? Ever see my slide?
No, we don't see your slides yet.
Okay, I see that. Check that. Yeah, it should be okay.
Yep, now we see your slides.
Okay. So, good morning. So today I will present the topic is arthroscopic surgery for CMC arthritis of the thumb. So I'm Dr. Shi, come from Taiwan, Taipei. So it's my disclosure. So from the history, we know that Dr. Chen is the first demonstrate how to use the arthroscope into the wrist joint. But the basal joint in 1996 is Dr. Meno have demonstrated the technique. So around the basal joint, we know that it's a subtle joint, it's relatively unstable. And the surrounding joint, we have the 16 ligament surrounding the joint. So the most important primary stabilizer is the AOL, is around the big ligament here, volar side, and the dorsal side have the DRL. And from the cross section, transverse view of the MRI, we can see that the APL and FCR around bilateral side of the trapezium. So we always use the APL or FCR tendon to do the suspension to increase the stability of the basal joint. For ear-turn stage, for the X-ray, for the arthritis from the 1 to 4, the type 1 is just the instability, and the type 2 is narrowing. Type 3 is more marked narrowing and the cyst formation, and type 4 is the STD joint involved. So Bhatia also demonstrated arthroscopic finding. So type 1 is the synovitis and the soft control bone and the vibration. And the type 2, we can see that the focal osteolytic deletion and the synovitis. Type 3 is a total loss of the cartilage. So it's, you can see that only the subcortical exposure. So from the portal setup, regular portal is from the bilateral side of first compartment is 1R and 1U. And from the 1U, the scope from the 1U portal, we can see the big ligament, volar side ligament here. And the 1R portal, and we can see the dorsal side of the basal joint. So even the fracture, yeah, you will have to use the scope. We can do the good assist reduction, the fragment, the big region, and give the KY fixation. Then we change to a screw that can provide good stability. And actually, we can make the good congruence of the joint. And in time, we can find how about the soft tissue injury. So for the early stage of the arthritis or basal joint, we can use the thermal syncage for our ligament instability. Because the basal joint, the ligament always is flat, not a bundle, and always continuity, just the elasticity, and it's very short. So, and it or more permit the effective absolute immobilization for a while. So very early before, we used the thermosynchrony around 16 to 17 degree to treat the instability of the basal joint, and here it can get a good result. So for the early stage, is a good result. Use the radial flexion probe, and then we know that basal joint also innervation by the radial nerve. So when we use the thermosynchrony to do the capsule, also have the capsule neuronectomy effect. So many people have demonstrated that good effect after the thermosynchrony to the capsule, and no any jackal joint, and keep the proprioception. So such a case is 19 male is trauma for 1 year instability. We can use some debris and do the synovectomy and use the thermosynchrony to do the AOL ligament. Yeah, it's a volar capture here. Can get the range of motion and the power. Another case, yeah, it's also do the synovectomy and use the KY to fix to 8 weeks. Yeah, it's can get a range of motion and a good pitch power. So more, if your patient have the more severe arthritis, such as the stage 3 or severe type 2 or stage 2, you always have the two problems: is the instability and arthritis. Yeah, your patient is a man or worker, need a power. We can do the fusion of the basal joint. So we can use the technique of the focal couple fusion technique. We debride both sides of the joint and give some bone graft put inside. Even use inject some BMAC, increase the healing property. And we use the small compression screw to increase stability and get a union rate. So also can use the clay to fix and fusion the joint. And actually in Taiwan now, arthroplasty also available now. So for instability, we can do the tendon suspension and interposition. For the arthritis, we can take the whole trapeziectomy or partial trapeziectomy, and also give the some soft tissue interposition. So such a case 45, a male worker, yeah, he debride because he is a worker, so need the power. So he debride both sides of the joint and use a screw fix. And you can see that 2 years later, I think get a good result and not bad power. But you can see the STD fusion, STD joint a little bit narrowing. I think have the some problem, but this patient no symptom about the STD. So more severe type in open procedure is LRTI. It's a ligament reconstruction and tendon interposition for the more severe stage 2 or 3 or even stage 4. In traditional method, is use the open method, take out all the trapezius bone and use the partial FCR and to do the suspension. So for arthritis, you can take whole the trapezius. So actually, is destroyed ST joint. So ST joint actually is destroyed and involved, and ST ligament also destroyed. So maybe we will create a scaffold instability actually. So for the tendon suspension, many kinds of methods have a study have to do that. You can use the FCR to make a bony tunnel and wrap with the APL, and you can also use the APL to wrap the FCR. Even use the free tendon to wrap bilateral APL and FCR. So under scope, we can use this method to increase the stability. So arthroscopy, partial trapeziectomy and LRTI, and also we use the internal breast can help our patient. Indication is 2, 3, and 4 arthritis. So we take a free tendon and we change the portal with the APL portal and FCR portal. Make a more longitudinal insertion, make a portal, and under the skin, we can see that easy to find that APL and FCR. So under scope, we take a partial trapeziectomy, also including a TT area, the tubercle of the trapezius area, and after that, after the resection, we use the thermosynchrony to the volar side, the big ligament, and apply the anchor to the second metacarpal base area. then we can do the internal press, and also can use the anchor to fix our tendon bone. Such a case is stage 3. You can see that is arthritis of basal joint. So we tendon graft from the volar side, use palmar-longus, and we will use the APL portal and FCR portal. Under scope, we can see that we take out the TT of the trapeziectomy joint and also take out 1/3 of the trapeziectomy bone. So under scope resection, the partial resection of the trapezium and use the thermosynchronization over the volar ligament and big ligament area. And then we make suture anchor. After we resection the TT, we can easily find the second metatarsal base area, apply the soft anchor to the metacarpal area, and then we can use the tendon graft through the joint from the FCR portal to APL portal. APL portal under the skin, we can wrap the APL tendon, then the tendon graft then back to the FCR portal, then we wrap with the FCR portal and tie. So residual, the tendon graft, we can make a tendon ball and the anchor, then back to the ACL portal and catch the tendon and put inside the joint. So this is a case we can see the joint, the tendon ball put inside the joint. So our procedure is that yellow color is the tendon graft, is the wrap with the FCR and the APL. The yellow color is the suture anchor. Yeah, we can also use the internal press and also fix the tendon ball inside the joint. And after that, we require to fix the 4 to 6 weeks to get 1 year later, get a range of motion and power. And 2 years later, yeah, we can say just a little bit cross migration, just 1 millimeter. And also can combine with suspension system like the cross link. Yeah, so we can do the suspension LRTI and combine with the suspension system. So we do the around many patients about in our series, and our result is that the 1 year later, just the proximal migration about 2 millimeter, and our result is better than the open procedure, can keep the range of motion and keep the pitch strength. So our reference also published in this month. So it's stage 4, even the stage 4, yeah, the STD joint involved. On the scope, we can take out all the trapeziectomy bone, but we change the more big burr to remove the trapeziectomy bone, but need more time. Always need 3 hours, 30 minutes or 40 minutes, yeah. And after that, we'll also do the web suspension procedure. And this patient due to the more space, so we use cross link, micro link to do the suspension system after the procedure. Yeah, 2 years later, 1 year later, we can see that just more migration 2 millimeter is improved very much power and the range of motion. So I have some miniature for ODM. Yeah, it's should be remove the TT region and easy to find to take out the spur. We can increase the range of motion. Internal press are very helpful for fix the tendon ball and also increase the stability. And in our series, it's better than the open procedure. I think the technique is not so difficult. It can keep all the basal joint pattern and the ligament pattern. Yeah. And soft tissue in procedure, I think it can tension the ligament, also increase the stability in arthritis. I think allow a little bit proximal migration, but it's okay. Okay, thank you very much. It's my presentation. Thank you.
Thank you very much. That was amazing. So next, I'd like to invite Dr. Esther Chow to talk to us about her take on arthroscopic surgery for thumb CMC arthritis.
Thank you very much. This is my honor to be here. So thank you very much for the invitation. So can you see my slide?
Yeah, it's
yes.
okay. Yeah.
Okay. So today I'm going to talk about first CMCJ arthroscopic arthrodesis, a little bit different from what Professor Shi is doing. So as we all know that CMCJ osteoarthritis is commonly affecting postmenopausal women, and it is the most frequent site in the upper extremity in need for surgery. The common surgical options include LRTI, fusion, and arthroplasty. And traditionally, these surgery are performed as an open surgery, and they are not without complications. For example, LRTI, there's reported to be 22% of complication rate, especially if there's a tendon adhesion or rupture and instability of the first ray. Fusion has problem of implant impingement, and non-union rate was reported to be as high as 48%. Arthroplasty also had high rates of complication and reoperation. So how about arthroscopic treatment? So the advantages of first CMCG arthroscopy as in other arthroscopy is that because you don't need to open up the joint, it can avoid destabilizing the capsular ligament structures of the joint. There's less pain post-op and has faster recovery. The first thumb CMCG arthroscopy was reported by Menon in 1996, while Dr. Berger is the first surgeon who performed the first CMCG arthroscopy. So from the literature, what can be done by arthroscopy? We have already heard what Professor Shi has told us, that he will do trapeziectomy and suspension. But in general, what can be done by arthroscopy include debridement with or without interposition, thermal shrinkage, trapeziectomy only with interposition, or trapeziectomy with some kind of suspension. So anything else we can do? So with the inspiration by Dr. Eva Maria and Dr. P.C. Ho with their successful results in arthroscopic partial wrist fusion. So I think probably arthroscopic first CMCJ fusion is a good option, and this become my favorite operation. So I'll briefly talk about how to perform this procedure. For the setup, it is similar to that of a wrist arthroscopy. So the surgeon is standing on the shoulder side of the patient using a traction tower. It can be done under general or local anesthesia, and I use a 3-liter saline bag for irrigation. So these are the instruments, small arthroscopic instruments used. I would like to use a 2.7 millimeter arthroscope for this procedure. So I'll first locate the joint by putting a needle in the joint and then confirm it with a C-arm. And then I'll use a traction tower with a 5 to 10 pounds traction. And I'll tape the hand such that the dorsal of the nail is facing the surgeon. So the standard portals are the 1U and 1R, which is named after the first extensor compartment. So 1U is ulnar to the EPB tendon and 1R is radial to the APL tendon. So first I'll do a debridement because usually inside the joint you will see a lot of synovitis. So I clear up the joint with a shaver. And then I'll further clear up the joint with radio frequency probe so that I can see the joint more clearly. So after all the debridement, you can see the joint quite clearly. For example, in this case, you can see there's eburnation of cartilage up to 80% of the joint. So I have no hesitancy to fuse this joint. So I'll further remove any remaining cartilage with a small curette through the arthroscopic portal. And then I'll burr the subchondral bone with a 3.0 millimeter burr until you can see bleeding from the underlying cancellous bone. So after burring, you can see bleeding from the trapezium, and you can also see bleeding from the opposite side, which is the metacarpal base. If there's inadequate bleeding in some site, you can use a chondral prick to induce more bleeding. This is quite important because a good bleeding from the fusion surface is very important to have a successful fusion. So now the joint is ready for fusion. So I'll take off from the traction tower and put in K-wire. So for the positioning, the thumb is in a key pinch position. So my little trick is put a piece of gauze at the first web such that the tip of the thumb is resting comfortably over the middle phalanx of the index finger. And also we need to reduce the joint. On the lateral view, we need to reduce the dorsal subluxation, and on the AP view, we need to reduce the radial subluxation. And then with manual compression, and we'll put in 2 K-wires. Occasionally, if we want to get more compression, and if the bone quality is good, I'll exchange 1 K-wire into a headless compression screw. So here are the fixation methods, either 2 K-wires or 1 KY and 1 screw. And then the patient is put in immobilization with a cast or a splint. And this is case example, 59 years old lady, left CMCJ OA. So there's a severe pain. So arthroscopic fusion with 1 KY and 1 screw is performed. So this is 6 months. There's a good improvement in pain from 8 to 2, and good improvement in grip strength from 18 to 22, and pinch strength improved from 3.8 to 5. And at 2 years, there's further improvement in the pain, grip strength, and pinch strength. And you can see the range of motion is actually comparable to the normal side and improved compared to pre-op. So a local study has been performed to see the effectiveness of this procedure. So the study is performed from 2015 to 2020 with a minimum follow-up of 24 months. We include Eton 3 CMCJ osteoarthritis treated with arthroscopic fusion and exclude those with inflammatory arthritis or with previous open surgery. So we perform objective and subjective assessment at pre-op and post-op 3, 6, 12, and 24 months. So for the results, there's 18 thumbs in 16 patients, average age 62.2, more female than male patients. Most of these patients are housewives. So the pain score has a good improvement as early as 3 months and continue to improve with time. And for the grip strength, initially there's a slight drop, but with time it improved, and subsequently there's definite improvement compared to pre-op. For the pinch strength, similarly, there's initially slight drop, but later it improved with time. The DASH score shows a good improvement as early as 3 months and continue to improve with time. For the Kapahanji score, the IPJ and MCPJ range of motion, there's no change compared to pre-op. There's no wound complications, no neurovascular complications. There's one case of pseudoarthrosis, but the patient remained asymptomatic. Another case, 76 years old lady, this time is right side for CMCJ osteoarthritis, Eton 3. So similarly, procedure was performed with arthroscopic fusion. So let's see. So we put in 2 KYs for this lady, and at 6 weeks we remove the KYs and remove the cast. So the patient is doing well at 6 months. You can see the pain score improved from 7.5 to 1, and the grip strength improved from 7 to 14, and pinch from 1.3 to 3.6. And at 2 years, the patient continued to do well, and the pain score improved, and the grip strength and pinch strength further improved. So sometimes I have difficulty in seeing which side is actually the operator side, because it seems that the operator side is actually having a better range of motion. So at 3 years, you can see the patient is continuing to do well with a very good range of motion. So by looking at this mini C-arm screening, you can actually see there's a very good compensation motion at the STT joint and the MCP joint. Therefore, the patient actually has a very good range of motion, even with the first CMCJ fused. So a very commonly asked question is about the adjacent joint osteoarthritis. So how common is the STT arthritis? So in our series, there are 7 cases has been operated for over 6 years. Over these cases, 5 of them has no STT joint arthritis, such as this lady, 55 years old, with CMCJ fusion for 7 years. There's no STT joint arthritis radiologically, and she remained asymptomatic. However, 2 cases did develop STT joint arthritis radiologically. However, there's no symptoms clinically, so they all doing well. So comparing the arthroscopic fusion with other arthroscopic techniques, we can see that the improvement in pain, the improvement in DASH score, and improvement in grip and pinch are comparable to other arthroscopic techniques. So in conclusion, I think arthroscopic first CMCJ fusion is a safe and effective options for CMCJ osteoarthritis. It has the advantage that it allows clear assessment of the joint. So before you do the fusion, you can see the joint clearly before you consider a fusion. And also it can allow better range of motion. I think the reason is that because arthroscopically, you have less disturbance of the capsular ligament structures and less adhesions. Therefore, the patient will have better range of motion post-op. And also it can have a better union rate because arthroscopic procedure can better reserve the blood supply. So I would like to invite all of you to join the 2025 Hong Kong Wrist Arthroscopy Workshop in December this year. Please take a picture of the QR code and then register. And I would also like to invite all of you to join this AppWa video challenge. And you can take a picture of the QR code and join the video challenge. Just send us a 5-minute video and you can win a free registration for the next AppWa meeting. I would also like to invite all of you to join the FASH Academy course, which will be held in Hong Kong next year, March. So thank you very much.
Thank you so much, Esther. That was really amazing results. So we'll take questions in just a little bit, but next up, I'd like to invite Dr. Marco Rizzo, who's going to talk to us about open techniques for management of thumb CMC arthritis. Marco?
Can you hear me, Harvey? Okay,
Yes, we hear you.
good. Thank you. I'm going to share my screen if that's okay. That was really impressive, Professor Chow. Thank you for sharing that. I'm a huge fan of fusions, and it's just wonderful to see the outcomes you're getting. Can you see my screen okay?
Not yet. Now we see it.
You see it? Okay. I'm going to go to presenter mode. Everything okay?
Yeah, everything looks great.
Great. Thank you. So my charge is, thanks again, Harvey, for the invitation, as well as Sanu for running these series. It's an honor to be here and a privilege to come and share and learn. I have no relevant conflicts. We've discussed certainly the importance of the thumb and its functionality in terms of grasping, pinching, manipulating, and lifting. It's such a critical part of our lives, and you can certainly appreciate why basal thumb arthritis can be so disabling to some of these individuals and patients that we have. It is a shallow articulation, and with 4 different articulations, including the index metacarpal. As a result of it, there's a lot of ligamentous attachments, which Professor Shi nicely showed us, and as a result, there's a lot of strain on those ligaments. In addition to that, there's a lot of load that goes in association with pinching. So when you combine these 2 factors, along with the shallow articulation, you do run the risk of having problems at this joint over time. And from a pathophysiologic perspective, it's basically the way, in a simple-minded way, I think of this, is that over time those ligaments get stretched and attenuated. This is why I think women are more affected than men. And there's more shearing. As a result of more shearing, there's increased cartilage loss, and the seeds of those laxities that we sow much earlier in our lives usually manifest themselves around the 5th or 6th decade as frank arthritis. There's a lot to consider when you're deciding how to treat these patients. You know, the age, occupation, their pre-op strength is something that's important to me. What the MCP joint is doing is also very important. And the clinical, as much as radiographic status of the STT joint. I think these are all critical to me. A lot of folks with STT joint arthritis don't have much pain. So I don't know that STT arthrosis is in and of itself is a contraindication to a procedure like Professor Chow was showing with the arthrodesis. It does, however, come, I think, with limited motion. One other point I think is important, that once you remove this trapezium, that decision should not be taken lightly. There's no going back after you take it out. And you can have a myriad of patients, which thankfully are rare, but a myriad of them that have a lot of difficulties, especially those who have difficulties maintaining their strength or are disappointed in their strength improvement or loss after surgery. It's a very good pain relieving procedure, but it's not a very good strength improving procedure, the trapeziectomies. I do like the Wilson osteotomies as for early arthritis, and but my big go-to for early arthritis and people who have STT spared is the fusion. And I love this procedure for younger folks who have a well-maintained STT joint space, and even some who have an asymptomatic STT joint. But for pantrapezial arthritis, the LRTI and suspension plasty remain at least the most commonly done in the U.S. Suture suspension is very up and coming and common, and but I tend to reserve suture suspension for reserved or failed cases, largely because I'm a product of that training with the LRTI. Peter Stern nicely stated to me one time, he said, this problem is solved once you take out the bone. You may inherit other problems after taking out the bone, but the arthritic problem is solved when you take out the bone. And more, we see suture suspension being very popular. As a board examiner for the ABOS, more of the younger surgeons are doing suture suspensions as their go-to for this condition. I'm going to talk you through a couple options. I like the LRTI, that's been my preferred, but also I'll share with you a case of a YLB or suspension plasty that with it we can highlight some tips and tricks. The procedure, the exposure I like to use for the LRTI is a Wagner incision. I go between the APL and EPB, and I split the periosteum off of the trapezium and elevate flaps as best I can. You can remove the trapezium out a couple ways. Make sure you identify the radial artery and as well as the superficial branch of the radial nerve with this procedure. The radial artery is vulnerable, mostly dorsally at the STT, and the SBRN is more superficial and usually dorsal from this Wagner incision. There is occasionally a terminus of the lateral antebrachiocutaneous nerve that you'll see on the volar side, so be cognizant of that, particularly when you make the hockey stick incision with the Wagner incision. You can remove the thumb trapezium two ways. Some folks like to remove it in toto. I prefer to do a piecemeal. I think it's safer, and for residents in training, I think it's a better way to take it out. Once you've taken out the trapezium, you can see the FCRs right here. You can identify the STT joint, and you can address the STT. My go-to for that is to the scaphotrapezoid joint, and I take a couple millimeters of the trapezoid in those cases. For the first few years of my practice, I used to take half the FCR, but now I take the whole FCR. I don't know that it's a difference. I was a little disappointed in the amount of fill that I got when I took half the FCR. And the FCR can be taken through 1 or 2 incisions more proximal. I go about 13 centimeters from the distal wrist flexion crease as in general. And after I've harvested the FCR, I follow that all the way down to its insertion. I prepare the base of the metacarpal. I use a K-wire followed by a cannulated drill to sort of get the trajectory. The ideal is to have the hole come out at the beak ligament, if it's all possible, but anywhere along the base. But you want to be sure that you make sure that you have enough of a bony bridge so it doesn't break when pulling the tendon through. The larger the tendon, the more difficult it is to pull, so you may need to use awls to increase the size. I use a 28 gauge wire to pull through, and that seems to have worked best for me in terms of pulling the tendon through the hole. At that point, I then suture the tendon to the capsule while distracting and adducting the thumb base so as to maximize the trapeziectomy space and secure it. And this is done with a fiber wire suture. then I'll use a couple double arm 2.0 ticrons to sort of first bring the tendon back to itself, and then to create the anchovy. And you can see the anchovy being made here on the left, and then pushing it down to fill the space. And that's basically the procedure in a nutshell. And I immobilize them for about 4 to 6 weeks. Some folks do less, but and that seems to work for me. You can see in this x-ray the highlight of the trajectory for that. You know, it is important, unlike CMC fusions where I feel like I can ignore the MP joint. In these cases, you want to make sure you address the MP joint, especially in cases that are egregious like this. And this one was fairly straightforward to make a decision for fusion. Volar capsodesis is a good option for folks with less extensive MCP hyperextension. If you don't address this, they're going to have biomechanically disadvantaged thumb as well as some frustrations, and they won't rehab as well in these cases of trapeziectomy. Overall, the results are pretty good. Most patients are satisfied as long as you set expectations. That's the important part. Some folks have had weakness and have been frustrated, and that's been a source of frustration for all of us. Radiograph subsidence is an expectation, not a complication. And it's important to let them know that ahead of time, especially if you get x-rays. I know some doctors don't get x-rays after the first one or at all after the procedure. But if you get your x-rays, you'll see that they subside. You can have intraoperative problems I touched upon a little bit. Reoperations, thankfully, are rare if you set expectations appropriately. And nerve and artery problems, thankfully, have been rare, but nerve problems can be quite troublesome. That SBR nerve can be very unforgiving at times. I'm going to extend briefly and talk about some complications that I've seen. I could fill all day with some of the things that we've seen, but this is a subsidence and persistence pain is not an uncommon complication that people have, and in these cases is where I consider the suture suspension with an inner position. And this formula seems to work. Dean Soterianos has a nice paper that highlights, you know, an algorithm on managing some of these, and I think that this is it's worth everyone having one, because even though these are rare, you'll see them. I'll briefly go over the suspension plasty. There's various types: the Wild Bee, Cheruzo, Thompson, Dr. Beckenbauer used to took the, and Dr. Shi nicely highlighted these methods. I'll take you through a quick case of a 54-year-old nurse who this incision, the Moberg type incision, a little bit of a modification from the Wagner, can be used. The FCR in this case is half the FCR is being harvested after you remove the trapezium. You can, in this case, we removed it completely. The FCR is pulled. Now remember, if you're going to take half the FCR, you want to take the ulnar half proximally, because it does a 180-degree turn, so that you're ultimately getting the radial half. If you screw this up, it's not the end of the world, in my opinion, but it is a style point. You want to reapproximate the FCR sheath after removal of the half of the FCR, and then you weave it through in a figure-8 fashion back around the APL and back onto itself. Interestingly, in Wildby's technique, he had a good amount of decurvain tenosynovitis after the procedure, and I think it was about 8 or 10%, and I think sometimes this is related to over-tightening this. So I would caution over-tightening, although it hasn't really been a huge problem in my experience. And after you've done a weave, you secure it with a 2.0 ethibond, and then you take the rest of it and pack it into a space, like the anchovy. And basically, that's the procedure. Again, mobilization is no different, and outcomes are very similar to LRTI in my experience. Some of these will fail and they'll lose abductions. Some of this is a predisposing pre-op issue, and this is a case of a patient who had MP exaggeration of her MP hyperextension after a suspension plasty. And what I find, a lot of these patients don't have pain; they're just frustrated. So in this case, I think a nice trick is to consider an osteotomy. and that helps to give them a better functioning thumb, especially if they don't have pain. A little bit like what you would see with end-stage arthritis, where someone is painless, but then sort of auto-fused. You just want to reposition the thumb in space so that they can have a better functioning hand. So in summary, the trapeziectomy procedures still remain common, although we're hopeful that we'll be able to evolve into something that's more in line with our friends in the hip and the knee. There is a forthcoming FDA approval for some of the implants that have been very successful in Europe. It's indicated, I think, for less physically demanding patients and patients with pan-trapezial arthritis in my practice. Like Dr. Chow, I'm a huge fan of the fusion. Pain relief is more predictable than strength improvement. Of course, a consistent technique, like a lot of things we do, and meticulous technique help optimize outcomes. The salvage options can be varied, and don't forget to address the MCP joint, particularly when you're thinking about trapeziectomies. Thank you very much for your attention. Again, thanks, Harvey and Sanu, for the invitation.
So thank you, Marco. That was amazing as usual. Certainly open techniques are the most commonly used in the US, but what I've always been impressed with is how well you do all of these. So thank you again for taking the time to teach us. So Sammy is not able to join us today because he had an unexpected commitment. So I'm going to move on a bit earlier to the Q&A. So I'd like to have the speakers just turn on their video if that's okay. And we'll also address the questions in the chat. So the first question I have is actually for Dr. Chow. So I think those are really amazing results with arthroscopic CMC fusion. I want to ask you, are you still, I mean, clearly you have great results, but how do you make the decision as to whether to perform an arthroscopic CMC fusion compared to like an arthroscopic, like partial trapeziectomy and suspension plasty? Are you doing mostly fusions in your practice now?
Thank you very much for your questions. I think after seeing the results of the arthroscopic fusion, I think it's I will not change to another options because it is a very good options. The result is good, unless the patient has also has an STT arthritis like an Eaton 4 CMCJ osteoarthritis. In that case, I probably will not do a arthroscopic fusion in those cases. Then I would do hemi trapeziectomy and suspension with a mini tightrope. But interestingly, in Chinese population, and I'm not sure in Taiwan also, Eaton 4 CMCJ osteoarthritis is quite rare. It's more common to have Eaton 3 CMCJ osteoarthritis. So very, very rarely I need to like do the other options. So most of my patients they do well with arthroscopic fusion.
Great. How about Dr. Shi? How do you make a decision as to whether are you performing arthroscopic fusion as well, or are you still doing mostly for like stage 2 or 3, like hemitrapeziectomy and suspension plasty? How do you make the decision as to what to use for your patients?
It depends the patient need. If the patient is a male and need a power, I will do the fusion. Same as the ISTE says that when we do the debris and decortication both sides, and make sure have the breathing from the both sides. That can make sure and promise that make good urine rate. Otherwise, if no blood from the both sides, you will worry about the non-urine. Yeah, but in patient, if smoking, yeah, it's a risk of non-urine. But now in Taiwan is a variable for BMAC. So he also inject some BMAC and take some bone graft inside the joint. That also have the increase the healing potential. Yeah.
And
But
Marco,
also in Taiwan, is very rare in stage 4.
and Marco, I know you've talked about this before as well, but your indications for fusion are like for somebody who wants a greater pinch strength. Is that correct? And do you have any other indications to decide for a fusion?
Yeah, I've over the years I've done more and more fusions, and yeah, you're right. STT spared the textbook indications: younger patient, heavier demand, STT joint free of arthritis. Now, I've gone and I've expanded some of those based on individual preferences. For example, yesterday I did 2 fusions, and one was a 69-year-old who had some STT arthritis, but she was a very avid golfer. Was worried that she was going to have trouble with her strength, even though many people who have LRTIs do fine with golfing, in my opinion. It's the ones that have pinch needs that really have trouble, if at all, with the LRTI or the WildBe. But she really embraced the concept of a fusion. One advantage of the fusion, you don't burn any bridges. You can graduate it to a trapeziectomy at some point, not to trivialize a second surgery, but this is something that I share with the patients. And the other one was a 70-year-old who's a heavier worker. He still worked. He's a farmer. And for him, he didn't have much by way of STT arthritis, so it was a little bit more straightforward. I'm actually struck by Professor Chow's experience with the motion improvement. I have in our series initially when we published, we found that many of them were able to have STT compensatory motion, but not to the degree that we're seeing with her experience, which suggests that that arthroscopic technique maybe eliminates some of the scar tissue that we see with diffusions. I worry a little bit, though, Harvey, about patients who have MCP limited motion. So, there's a variability of that MCP motion. So if they don't have much, I lay some crepe. I say, look, this is something that you may experience more frustrations as a result of post-op because you don't have that flexibility. Now, many of them will improve that MP motion out of necessity, over time. But I don't have enough gift of prophecy to say I know how much or whether they'll be ultimately satisfied in the end. One of the beautiful things about the fusion is I can ignore the MP joint. Even if they have significant MP hyperextension, once you put them in the position of fusion, even if they have a slight further and they still have some evidence of MP hyperextension, they are not frustrated like the trapeziectomy folks. The MP joint can be ignored in the fusion, and that's a real nice feature that the fusion has over the other procedures, in my opinion.
That's a question. Thank you, Marco. And then there's also a question in the chat about the use of bone graft. So I'd love to hear from everybody on the panel. Do you use bone graft? And if so, where do you get it from?
So maybe I start first. So for me, I do not use bone graft. Sometimes when I burn the bone, I will leave the debris inside the joint. Those may be just like a bone graft, but I will not take additional bone graft to add into the joint. I think the bleeding, as Professor Shi also agree, is more important for the fusion than any bone graft.
Yes, I always put some matrix of bone graft. If the patient have a smoking history, I will put the bone graft because I use the small bird. When we debride both sides, the congress is so not so much, so have the chip, not so smooth. So I put some bone matrix to make the good context, a good approximation. So and we also use the BMAC. Yeah, we take the bone marrow blood and the concentration and inject the vessel joint. Also have the help for the bone ingrowth. Yeah, bone healing.
How about you, Marco?
Yeah, I use bone graft. I use allograft. I used to use autograft, but I graduated to allograft, and mainly sort of the coconut sort of shavings type of graft. A lot of the folks who require fusions are adducted, so you want to get the thumb out. I usually like to position them in this position for fusion. I think of Bill Clinton. I don't know if anyone remembers Bill Clinton, but when he was president, he would make his points this way with his thumb like this. And I tell my patients, this is the position of fusion that I'm going to put you in. But you have to sometimes do some carpentry on the base of the metacarpal to get it out from that adducted position. And it's really an art in trying to maximize bony contact while contouring the bone and position them in the thumb of fusion. And I've learned much better at it now than I was 15 years ago, 20 years ago. And I sometimes will fill bone graft. I like the idea of the bone graft sort of filling some of the limitations I have, because sometimes I feel like I have to do a little bit more carpentry than I'm comfortable with. The other advantage of bone graft is it helps some of them, not so much on the metacarpal side, but on the trapezial side. Some folks have really sclerotic trapeziums, and you're burring and you're burring. You're trying to get down to that punctate bleeding and you're taking a lot. So I think there's advantages to creating these little craters, like to breed and then create these little craters to sort of help stimulate bony cancellous bone, and I pack bone graft into those craters to sort of help maintain the size of the trapezium so I'm not taking so much, at the same time stimulate that healing and bridge that healing. I don't know, I don't have hard science that says that's necessary, but it helps me sleep better.
Thank you. And I know we didn't get to talk about denervation today, but I'd love to ask the panel, do you use denervation in your practice at all? And if so, what are your indications for thumb denervation? Dr. Chow or Dr. Shi, do you all use denervation at all?
No, I didn't use denervation, but but the thermal like the radio frequency when I use for the hemostasis, I'm not sure if that heat energy may do a little bit of denervation. I have no scientific like I don't know. Maybe Dr. Shi has more experience.
Yeah, I have do the denervation for basal joint arthritis. Maybe some other kinds of condition I will do the nerve denervation. But I think the radio frequency is also very helpful for the capsule denervation. Actually, is that when we thermal the capsule and the ligament, and the effect is not bad. Actually, is that is my experience.
Marco, do you use denervation in your practice?
I'm trying. I've done a few, and I've had mixed results. My results don't really reflect what Sammy's been describing, and Dr. Boy, I'm blanking on his name over there too, who also does a lot of the denervation, has popularized it. It was very popular at the AAHS. There was a lot of discussions about thumb denervations and denervations in general. But my results, I think, mimic a little bit of my results with wrist denervation. And I think a lot of it is, I say this, I've said this before, you may have heard me, Harvey. I gave a talk at the Jupiter Forum at Harvard at Mass General a few years back, and it was on the wrist denervation, and David Rain got up and said, "Marco, that's a sham surgery. It's just a placebo." And he was really challenging the procedure, the validity of it. And he said, if you really want to justify it, you need to do a sham surgery. You just need to make an incision and do nothing, and compare it to people who actually get denervated. Of course, that's not going to get any IRB approval here, at least in the U.S. I don't believe. But I think there's something to that. I think our enthusiasm for the procedure is contagious. And if you tend to be a good, enthusiastic, positive individual, I think you get better results. And that's why Dick Berger, I think that's why Dr. Berger's results were so good, because he's just a generally optimistic person. I tend to be a little bit different. I tend to be more of a crepe layer. I talk about all the bad things that can happen. And I think that's contagious as well. Because I feel bad if I give them false hope that it's going to be successful. And my results with the wrist fusion are notably lower than what the published results, and my results with the thumb denervation are the same. That said, you don't burn any bridges, and I'd like to learn and share my own experience for folks who are interested. There's more and more patients who are coming looking for these types of procedures. They're quite knowledgeable, and they've read up on it online. I don't think the technique is super challenging, and I applaud trying to learn more about it, but my results have been about 50-50. Sorry, long-winded answer, Harvey, more than you need to know. I'm sorry.
No, it's always great to hear your insights. And I totally agree with everything you said. You know, I think certainly when we think about the innovation for the wrist, you know, there aren't many, I mean, the salvage options are not great. So the innovation really provides a good alternative. But for the thumb, like, you know, Dr. Chow and Dr. Shi showed there are so many options for early stage arthritis, like arthroscopic debridement and shrinkage, capsular shrinkage that works so well. So certainly if you're a skilled arthroscopist, I agree that, you know, the indications for the innovation will be somewhat limited. So, but again, it really speaks to the amazing cases that you have shown. So there's one more question in the chat about, does anyone do a prophylactic release of the first dorsal extensor compartment? So I think this is probably like for open surgery. So, so maybe I'll ask you, Marco, do you release the first dorsal extensor compartment?
No, not prophylactically, especially if they're asymptomatic. Now, I've done many where I treated both at the same time. And I certainly, you know, and for the younger surgeons or providers on the in attendance, you know, it's important as part of your workup to assess the first dorsal compartment and really scrutinize where the pain's coming from, because a lot of folks have concomitant first dorsal compartment pain and basal thumb arthritis. Sometimes even as high as 35% has been reported in the literature. But if they don't have any pain, I don't go after it. I appreciate Miguel's question, and I'd love to know what he does, even though he's not on the panel. But I don't know if that's is that allowed, Harvey?
You mean to ask us?
Dr. Perla Cruz.
Sure. I mean, we can have Miguel. You know, well, Miguel, are you here? Please.
Yes, can you hear me now? I don't know if you can you hear me?
Yes, we hear you, Miguel.
Yeah, the reason why I bring this up is because of the total CMC prosthesis. That was a high complication rate associated with the Quervans. I think it was almost as high as 20%. And I know that you know, we haven't discussed the hemiarthroplasties, but I do the prophylactic release of the first dorsal extensor compartment. And it is a known complication when you get swelling and you have some of these other postoperative things that happen postoperatively. So that's why I kind of throw it out there as a suggestion.
Great.
That's
Thanks.
a great question.
Thanks, Miguel. We're going to take one last question in the chat. So there's a question about, for Dr. Chow, how long does it take to do arthroscopic CMC fusion?
Thank you. For me, it takes around 2.5 hours. Because it actually takes quite long. Because the osteoarthritic joint is quite the subchondral bone is quite hard. So it takes some time to remove the subchondral bone. As I've said, I need to do a good to see good bleeding. So it takes some time to remove those bones. So it really takes some time. Yeah.
Okay, thank you. Well, I'd like to thank all the panelists for great talks, you know, and a great discussion on a Saturday morning. I'd like to thank our participants for joining us as well. This really has been an amazing global hand-in-hand session. I'm going to turn it over to Sonu for some concluding remarks.
Thank you, Harvey, for moderating and for being the series lead on our global hand-in-hand webinar series. And thank you to all of our world-renowned speakers for excellent talks on how to manage CMC arthritis so effectively. Marco, I lay a lot of crepe too. So special thanks to the Taiwan Society for Surgery of the Hand, our upcoming guest nation, and for the Hong Kong Society for Surgery of the Hand, as well for the collaboration on this webinar. I'd like to thank you, our audience, for sharing your day or night with us, and to invite you to join us for upcoming hand-in-hand webinars, as well as our other webinar series, and also to invite you to join us for our annual meeting in San Diego in January 2026. Further information can be found on our AAHS website, which is handsurgery.org. Good day and good night.
Yeah.
Thank you.
Thank you, everyone.
Have a nice
Have a good
weekend.
weekend.
Good day.
Thank
Bye.
you. Thank you.
Bye.
Bye. Bye.